Did you know that unintentional drug poisoning, it's the second leading cause of accidental death in the U.S.?
Wow.
Yeah, and get this, over 2.4 million toxic exposures reported every year.
That's staggering. Really puts it into perspective.
It really does. And those numbers, they kind of set the stage for what we're diving into today. So our mission here in this deep dive is basically to give you a shortcut to being, genuinely well-informed about how we treat medication overdoses. And here's maybe the surprising bit up front. Antidotes, yeah, they're absolutely critical sometimes, but they are just one piece. A small piece, often, of a much larger puzzle in saving lives.
Right.
It's easy to think of them as like the superhero cape, the thing that swoops in and fixes everything instantly.
That's the common idea, yeah.
But as we'll unpack, a broader structured approach isn't just crucial. It's often the actual lifeline.
Yeah, it's really eye-opening when you dig into it. How often public perception focuses just on that, magic antidote.
Yep.
When in reality, emergency medicine, toxicology, they rely on this whole comprehensive spectrum. 4 categories of intervention.
Category.
Understanding that big picture, it's fundamental to appreciating the incredible precision involved in actually saving a life.
Okay, let's unpack this then. 4 key pillars of intervention. And maybe it'll surprise you. The first one, arguably the most important, is supportive care.
The foundation.
Then we look at antidote therapy, then decontamination, and finally, methods to enhance elimination.
So, okay, if antidotes aren't the immediate go-to, why is supportive care the absolute foundation, the bedrock?
That's a great question, and it's critical. It's because most medications, even when someone's taken way too much, they can be safely cleared from the body. If the patient's vital organ systems, heart, lungs, brain, can be supported long enough, supportive care stabilizes the patient. It keeps everything running.
Okay. Buys time. Exactly. It buys the necessary time for their body's own processes to work, or for us to safely select and maybe administer other interventions, like an antidote, if one even exists for that substance.
Right.
And here's another sort of surprising fact. There are only about 40 known antidotes.
40 for thousands of drugs.
Yep, roughly 40 antidotes for thousands of possible overdose medications. So stabilization is paramount because, frankly, often it's all we have, or it's what makes everything else possible.
That makes perfect sense. So let's dig into these categories, starting with that really important one. Stabilization and initial supportive care. We're talking the basics here, right? The ABCs.
The absolute fundamentals: airway, breathing, circulation, following standard resuscitation algorithms. But there are also some specific, crucial initial interventions that might not be obvious to an outsider.
Like what?
Well, for instance, intravenous sodium bicarbonate. That's a go-to for certain heart issues, things like a prolonged QRS interval.
Okay, what's that mean exactly?
It just means the heart's electrical activity is taking a bit too long to reset between beats. Or for really dangerous, fast, irregular heart rhythms, ventricular tachycardia.
Right.
These can be caused by meds that block the heart's sodium channels. Things like older antidepressants, cocaine, even some antihistamines like diphenhydramine.
Oh.
Then you have intravenous benzodiazepines. Think of them as calming medications like diazepam or lorazepam.
Right, like Valium.
Exactly. They're first line for things like a super fast heart rate or those significant sympathomimetic effects.
The fight or flight stuff.
Yeah, that wired, agitated state you see with amphetamines, cocaine, things like that. They're also the immediate treatment for seizures caused by toxins.
And you mentioned other seizure meds might not work.
Yeah, that's important. Common anti-seizure meds like phenytoin, generally ineffective for toxin-induced seizures, might even make things worse.
Wow.
Okay.
And naloxone, of course, for opioids. We hear a lot about that.
Definitely. For respiratory depression from opioids, crucial. But also simple things like glucose for hypoglycemia, low blood sugar.
Right. And you mentioned something about thiamine before glucose. If there's a risk of deficiency, why that order?
Good catch. Yeah, if a patient is malnourished, maybe an alcoholic, giving dextrose sugar before thiamine can actually trigger a severe neurological disorder, Wernicke encephalopathy. It's a small detail, but potentially huge consequences. And then hyperthermia, right, dangerously high body temperature, that needs aggressive management.
High aggressive.
5-E benzodiazepines again, sometimes even temporary paralysis and intubation in really severe cases, plus immediate cooling. ice packs, cooling blankets, whatever works fastest.
So it sounds like rapid assessment is key, and it's not just about finding the right cure right away.
Absolutely. And what's really striking here is how often the patient's history is unreliable, maybe more than half the time.
Really?
That often?
Yeah. So a rapid physical exam recognizing toxidromes.
Oxidrome.
They're like signature symptom patterns. A specific set of clues like pinpoint pupils, sweating, slow breathing that point towards a particular class of toxin, like, aha, this looks like an opioid overdose. Recognizing those becomes crucial for guiding these initial rapid actions. It really underscores that swift, informed action based on what you see is key, not just waiting around.
Okay, so assessment first, but then what about stopping more of the poison getting in? That brings us to the second pillar, decontamination, stopping absorption.
Right.
And this is where it gets like really interesting because it sounds like some common sense approaches maybe aren't the best, and timing is everything.
Yep.
Like I remember old movies making someone vomit with syrup of ipecac.
Oh, definitely not. Absolutely no role for syrup of ipecac anymore.
Why not? Seems logical.
Well, it delays other more effective treatments, and importantly, it just hasn't been shown to actually improve patient outcomes, plus the risk of aspiration.
Makes sense. What about gastric lavage, stomach pumping?
Also generally not recommended. It might be considered in extremely rare life-threatening situations, maybe within the first hour of ingestion for certain specific things, but only if the risks aspiration again or even pairing the esophagus clearly outweigh what are usually pretty minimal benefits.
Okay. And cathartics, things to speed up the gut.
Like sorbitol, no role by themselves, and not recommended even with activated charcoal.
Okay, so let's talk activated charcoal. That's the one lots of people think is the universal fix, right?
Yeah.
Swallow something bad, drink charcoal.
Yeah, that's a common thought. But single-dose activated charcoal, or SDAC, it's not routinely recommended for most overdoses.
Most. When is it useful?
It's most beneficial if given quickly, ideally within 1 to 2 hours of ingestion, and only for specific toxins it's known to bind well to.
So it doesn't bind everything.
Exactly. And this is a critical point, a common misconception. It does not effectively bind things like iron, lithium, cyanide, lead.
Heavy
Right. Or alcohols, methanol, ethanol, isopropyl alcohol, or petroleum distillates. So if someone swallowed batteries or too much iron, charcoal won't help.
Good to know.
And a major reason we're cautious is the risk of aspiration. If the patient is drowsy, can't protect their airway, giving charcoal could mean they inhale it into their lungs. That's a serious complication.
That distinction about what it binds is huge, isn't it? Especially for any kind of home remedy thinking. What about multiple doses? More charcoal, more better.
Not necessarily. Multiple dose activated charcoal, MDAC, also not routinely used. It might be considered for life-threatening amounts of a few specific drugs, carbamazepine, dapsone, phenobarbital, quinine, theophylline, maybe certain mushrooms.
But does it actually work better?
Well, that's the thing. Despite what you might assume, even multiple doses haven't consistently shown better patient outcomes in studies. It highlights a critical nuance, you know. Often, the heroic measures we imagine aren't the magic bullet we hope for. The evidence sometimes just isn't there.
Okay. And the last decontamination method, whole bowel irrigation, flushing the whole system.
WBI, yeah. Also not routine. But it may be considered for toxic amounts of substances that charcoal doesn't bind.
Like the iron and lithium you mentioned.
Exactly. Iron, lithium, other heavy metals. Also potentially for sustained release or enteric-coated pills, the ones designed to dissolve slowly.
So it pushes them through faster.
That's the idea. Or for people who've ingested drug packets, body stuffers, or packers. So for healthcare providers, knowing exactly what charcoal binds, what it doesn't, and when WBI might even be an option, that knowledge is absolutely critical. It's not just academic.
It's clear that stopping absorption is complex. But what if the toxin is already already absorbed, causing damage? That's when we need to, speed up getting it out right. Enhanced elimination.
Precisely.
So this raises a question. How do these more advanced techniques become necessary? It's not just what you took, but how much and how fast your body is or maybe isn't handling it.
Exactly. These interventions are for the severe cases, where the body's natural elimination pathways, usually the kidneys, are just overwhelmed.
Okay, so what are the options?
One method is urinary alkalinization. This involves giving intravenous sodium bicarbonate to make the urine more alkaline, raising the pH above 7.5.
And how does making urine alkaline help?
Well, think about it like this. Many toxins are weak acids. When the urine is alkaline, these weak acids get ionized, they gain an electrical charge.
Okay.
And in that charged state, they can't easily cross back from the kidney tubules into the bloodstream, so they get trapped in the urine and flushed out more effectively. It also helps correct metabolic acidosis, that dangerous buildup of acid in the body.
So useful for things like aspirin overdose salicylates and phenobarbital and those toxic alcohols we mentioned.
Yes, recommended for salicylates, phenobarbital, and correcting acidosis in toxic alcohol ingestions. Also sometimes mentioned for methotrexate, chlorpropamide, and others, but there's a caution here about forced alkaline diuresis.
What's that?
That's combining alkalinization with giving large volumes of IV fluids to force more urine production. It's generally not recommended because of a high risk of fluid overload and sodium overload, which can strain the heart and lungs.
Okay, so alkalinization, but carefully. What if that's not enough? Or the kidneys aren't working?
Then we move to more invasive methods like hemodialysis or continuous renal replacement therapies, CRRT, essentially artificial kidneys.
Dialysis for overdose. When does that become absolutely necessary?
It's reserved for specific toxins when other therapies fail, or if there are severe acid base or electrolyte problems, or, like you said, if the patient's own kidneys are failing.
Are there rules for which toxins can be dialyzed?
Yeah, absolutely. For hemodialysis to work well, the toxin needs certain properties. It shouldn't be too tightly bound to proteins in the blood. It needs a low volume of distribution, meaning it stays mostly in the blood, not hidden away in tissues. It needs a low molecular weight, small enough to pass through the dialysis filter, and it needs to be water soluble.
Okay, so quite specific criteria.
Very specific. Things like ethylene glycol, methanol, lithium, salicylates, theophylline, valproic acid, those are some key ones we can dialyze effectively.
And CRRT, how's that different?
CRRT is a slower, gentler form of dialysis. It might be better for patients who are really unstable, maybe with very low blood pressure, who can't tolerate the high blood flow rates of standard hemodialysis. It might be a bit less efficient minute to minute, but safer for certain patients.
It's truly incredible, isn't it, how the specific, molecular structure of a poison dictates the exact treatment strategy.
It really is.
It just underscores the precision needed in emergency care.
Okay, let's take that deep dive now into some specific antidotes and the toxicities they treat. This is where the puzzle pieces really come together. Let's start with toxic alcohols. Methanol, ethylene glycol.
Right, and diethylene glycol too sometimes. The big danger here isn't the alcohol itself initially, it's what the body's enzymes turn it into.
They get metabolized into highly toxic acids. Methanol becomes formic acid that's really bad for the eyes. Ethylene glycol antifreeze becomes glycolic acid and oxalic acid, which hammer the kidneys. These acids cause severe organ damage, eyes, kidneys, brain, and that dangerous anion gap metabolic acidosis we talked about.
So the body accidentally makes the poison worse. What's the counter strategy? How do we stop that transformation?
The preferred antidote now is Fompazole.
Phobias.
Yeah. And what's really cool about it scientifically is how it works. It competitively inhibits the enzyme alcohol dehydrogenase that's responsible for that first step, converting the parent alcohol into the toxic metabolite.
So it blocks the enzyme, like a roadblock.
Exactly. It puts up a roadblock for that bad chemical reaction. It's safe, very effective, and much easier to use than the old antidote, ethanol.
Ethanol, like
Yeah.
drinking alcohol.
Yep. Ethanol also inhibits that same enzyme, but it's tricky. You have to maintain a very specific blood level. It causes CNS depression, low blood sugar. It's just much harder to manage, and there isn't even a standard IV preparation available everywhere. Fompazole has a precise dosing schedule, loading dose, then maintenance doses, sometimes adjusted if the patient's on dialysis.
His dialysis removes it too.
Right, so you have to give it more often during dialysis. But the key is it stops the formation of those toxic acids.
And besides Fompazole, are there other supportive things for toxic alcohols?
Oh, yes, absolutely. Adjunctive therapies are crucial. Hemodialysis is often needed anyway to remove the toxic acids that might have already formed before the antidote was given.
Ah, okay.
For methanol specifically, we give folic acid. For ethylene glycol, we give thiamine and pyridoxine, vitamin B1 and B6. These vitamins can help push the metabolism down less toxic pathways.
Interesting.
And you mentioned this earlier, there's that sort of quirky iatrogenic twist.
Yeah.
Propylene glycol toxicity.
Solvent in IV meds?
Yeah, like in some IV formulations of Larzham or phenobarbital, if given in large amounts or over long periods, it can build up and cause symptoms very similar to toxic alcohol poisoning acidosis, altered mental status. An elevated osmolar gap on blood tests can be a clue.
Fascinating. Okay, let's switch gears. Calcium channel blockers, CCBs and beta blockers, BBs. You said these are major causes of cardiovascular drug fatalities.
They really are. They can cause profound problems. Severe hypotension, low blood pressure, bradycardia, slow heart rate, and myocardial depression. The heart muscle just can't pump effectively.
Are there differences between CCB and BB overdoses?
There can be subtle ones. CCB overdose patients might, kind of surprisingly, stay alert but often have high blood sugar. BB overdose patients are maybe more likely to have altered mental status, respiratory depression. And interestingly, kids with BB overdose can get low blood sugar, hypoglycemia. And one specific beta blocker, propranolol, is kind of notorious for causing seizures and widening the QRS complex on the ECG, that heart electrical signal delay.
So the heart's in big trouble. What are the antidotes?
Well, first line is often calcium, given intravenously.
Calcium. Why calcium?
For CCBs especially, it competitively overcomes the blockade, allowing more calcium to enter the heart muscle cells, which helps them contract stronger. It works pretty well for mild to moderate toxicity. But there's a huge caution.
Which is?
You absolutely must avoid giving calcium if you or even suspect digoxin toxicity. It can cause a systole, complete heart standstill, very dangerous interaction.
Okay, critical point. What else? Glucagon.
Glucagon used to be more common. It works by increasing CAM-MP in the heart cells, that's a messenger molecule, bypassing the beta blockers effect. It works fast, but doesn't last long, and often causes pretty bad nausea and vomiting, sometimes hyperglycemia too. It's increasingly being replaced by something called HITE.
HITE. Hyperinsulinemia euglycemia therapy. Sounds complex. Insulin for a heart problem.
It does sound counterintuitive, doesn't it? But HITE works by improving the heart muscle's ability to use carbohydrate sugar for energy, basically helps fuel the failing pump.
Does it work quickly?
The benefits are often delayed, maybe 15 to 60 minutes to really kick in, so you have to start it early if you think you'll need it. It involves a high-dose insulin-loading bolus, then a continuous infusion, sometimes at very high rates, and you must give dextrose concurrently to keep the blood sugar normal euglycemia, hence the name.
What are the risks?
The main risks are hypoglycemia, obviously, and hypokalemia, low potassium. So it requires really intensive monitoring of glucose and electrolytes.
Okay. And then there's intravenous fat emulsion, IFE, injecting fat.
Yeah, IFE. It sounds really weird, I know.
How does that work?
It's actually a really promising antidote, especially for cardiovascular collapse caused by drugs that are highly lipid-soluble, fat-loving drugs.
Like what?
Local anesthetics like bupivacaine, many tricyclic antidepressants, and yes, CCTs and BBs, bupropion too. The leading theory is called the lipid sink theory.
Lipid sink.
Think of it like this. You infuse this large amount of fat emulsion. These tiny lipid droplets circulate in the blood and act like little sponges. They soak up the fat-soluble drug molecules from the plasma.
Trapping the drug.
Exactly. Creating this sink within the bloodstream where the drug gets sequestered, making less of it available to bind to receptors in the heart and brain, effectively reducing its toxicity. It's pretty cool.
Wow, that is cool. Okay, next up, cyanide. Sounds terrifying. House fires, industrial stuff.
Yeah, it's a rapid, deadly poison. Found in smoke from burning plastics and synthetics, industrial accidents, sometimes suicide attempts. It works by binding to a key enzyme in our mitochondria, cytochrome oxidase.
The cell's power plant.
Right. It basically shuts down aerobic respiration. Cells can't use oxygen to make energy, leads to rapid cardiovascular collapse, shock, and often death very quickly.
So how do you fight something that acts that fast at the cellular level? What are the antidotes?
We have a few options. Historically, there was the nitrate-based kit amyl nitrite inhalant, then IV sodium nitrite.
How do nitrites work?
They work by inducing methemoglobinemia. They change some of the hemoglobin in red blood cells into methemoglobin. This methemoglobin has a high affinity for cyanide, so it binds the cyanide, pulling it off that critical cytochrome oxidase enzyme.
Okay, but you mentioned a caution.
Yes, a big one, especially relevant in smoke inhalation victims. If they also have carbon monoxide poisoning, which is very common in fires-inducing methemoglobinemia, further reduces the blood's ability to carry oxygen, it can make hypoxia worse. So using nitrites in that setting is risky.
What else is in that older kit?
Sodium thiosulfate. That one works differently. It acts as a sulfur donor, helping the body's own natural enzyme, rhodinase, detoxify cyanide into much less toxic thiocyanate, which is then excreted by the kidneys. It's generally well tolerated.
And the newer option? Hydroxycobalamin, cyankit.
Yes, hydroxycobalamin. It's become a preferred option in many places, especially for empirical treatment of suspected cyanide poisoning, like in fire victims before lab results are back.
Why is it preferred?
Because it's relatively safe, it works quickly, it doesn't compromise oxygen carrying capacity like the nitrites can, and it doesn't cause significant hypotension. It works by directly binding cyanide. One molecule of hydroxycobalamin binds one molecule of cyanide to form cyanocobalamin.
Vitamin B12.
Essentially, yes. A very large dose of a B12 precursor forms vitamin B12, which is non-toxic and excreted in the urine.
Any downsides?
Well, it causes a very noticeable reddish discoloration of the skin, urine, and other body fluids. Looks dramatic, but it's harmless. More importantly, it can interfere with many common laboratory tests, colorimetric ones especially, so ideally you draw blood for labs before giving the cyanokit if possible.
Good tip. Okay, let's talk about digoxin-specific antibody fragments, Fab fragments. Digoxin is a heart medication, right?
Yes, digoxin is used for heart failure and atrial fibrillation, but it has a narrow therapeutic index, meaning the dose that helps isn't far off the dose that harms. Toxicity can also happen from ingesting certain plants like foxglove or oleander, which contain similar cardioactive steroids.
And the Fab fragments are the antidote.
Exactly. Digibine or Digifab. These are antibody fragments specifically designed to bind to digoxin molecules in the bloodstream.
Like targeted missiles.
Sort of, yeah. They bind digoxin very tightly, neutralizing it and allowing it to be excreted by the kidneys, rapidly reversing the cardiotoxicity.
When are they used? It sounds expensive.
They are expensive, so use is reserved for serious cases. Indications include life-threatening heart rhythm disturbances like severe bradycardia or ventricular arrhythmias, a very high serum potassium level, which is a marker of severe digoxin toxicity, or evidence of end organ damage like kidney failure or altered mental status, also used for very large acute ingestions.
What do pharmacists need to watch for?
Besides clinical improvement, monitoring the ECG and serum potassium is key. And a crucial point, serum digoxin levels measured after giving Fab are unreliable, usually for about 24 hours, sometimes longer. The lab test measures both bound and unbound digoxin, so the level will look falsely high even though the toxic effects are reversing. You have to monitor the patient, not the level.
Got it. Okay, switching to a really common one. N-acetylcysteine, NAC, for acetaminophen poisoning. Tylenol overdose.
Yeah, acetaminophen APK. It's incredibly common, found in so many products, and it's actually the second leading cause of poison-related deaths in the U.S.
Wow. Second, why is it so dangerous?
The toxicity isn't from the acetaminophen itself, but from a toxic metabolite called NAPQI. Normally, our liver detoxifies NAPQI using glutathione, a natural antioxidant.
Okay.
But in an overdose, the normal pathways get overwhelmed, glutathione stores run out, and NAPQI builds up. This NAPQI is highly reactive and binds to liver cells, causing severe liver injury, potentially leading to fulminant hepatic failure, complete liver shutdown.
And NAC is the antidote. How does it help?
NAC is absolutely life-saving. It works in two main ways. It acts as a precursor to glutathione, helping replenish the depleted stores, and it can also directly bind to and detoxify NAPQI itself.
Is timing important?
Timing is everything with NSC. If you give it within 8 hours of the acetaminophen ingestion, it's nearly 100% effective at preventing serious liver injury.
Yeah, 100%.
Almost. Its efficacy decreases the longer you wait, but even if someone presents late, even with established liver failure, NAC can still offer benefit, improving survival. So the rule is basically, if acetaminophen toxicity is suspected, give NAC.
How is it given? Pills? For?
It can be given both ways. There's an oral formulation and an intravenous one. 40 NAC is often preferred, especially if the patient is vomiting, has altered mental status, or already has liver failure. The oral loading dose, followed by many subsequent doses, tastes and smells awful, like rotten eggs, making compliance tough.
Any risks with AMAC?
The main issue with IV NAC is the risk of non-allergic anaphylactoid reactions. It's not a true allergy. Usually it's due to histamine release. Causes flushing, itching, sometimes hives or wheezing. It's usually manageable by temporarily stopping the infusion, giving an antihistamine like espafenhydramine, and then restarting the NAC infusion at a slower rate. It's a small price to pay for saving the liver.
Absolutely. Okay, next, Loxone for opioid overdose. Probably the most famous antidote out there now.
It really is. The most common antidote used in the ER, Noxone, brand name Narcan often, is a pure opioid antagonist. It competitively binds to opioid receptors, primarily the mu receptor, kicking the opioid off and reversing its effects. Most importantly, it reverses the respiratory depression, the slowed or stopped breathing, which is what kills people in an opioid overdose.
How is it dosed? Just give a big shot.
No, there's a really important nuance here, especially now with fentanyl and also with people who are opioid dependent. The recommendation is to start low and go slow.
Why low?
To avoid precipitating acute, severe opioid withdrawal. If you give a huge dose to someone who's dependent, they can go from unconscious to violently agitated, vomiting, severe pain. It can be dangerous and make further treatment difficult. So you start with a small dose, maybe 0.04 or 0.05 milligrams TFV, see if they start breathing better. If not, you give a bit more, titrating up incrementally until respirations improve. You just want them breathing, not necessarily wide awake.
And if they don't respond even to larger doses?
A lack of response after a significant cumulative dose, say 10 milligrams, should make you seriously reconsider the diagnosis. Maybe it's not just an opioid overdose, or maybe it's something else entirely.
And naloxone wears off, right? Often before the opioid does.
Exactly. Naloxone's duration of action is relatively short, maybe 30 to 90 minutes. Many opioids, especially long-acting ones or large amounts of fentanyl, last much longer. So the patient can wake up, seem okay, and then slip back into respiratory depression as the naloxone wears off. Repeat doses, or sometimes a continuous naloxone infusion, are often necessary, along with prolonged observation.
Crucial point. Okay, now flumazenil for benzodiazepine overdose. Drugs like Valium, Xanax, Ativan. This one seems intuitive, or reverse the sedation, but you said it comes with a big warning.
A huge warning label, yes. Flumazenil is a specific benzodiazepine receptor antagonist. It can reverse the CNS depression from benzos, but its routine use in overdose settings is generally discouraged.
Why discouraged? What's the risk?
The major risk is precipitating seizures. This is especially dangerous in patients who are chronic benzodiazepine users. Suddenly blocking those receptors can trigger severe withdrawal seizures. Also in mixed overdoses, which are very common.
Like benzos plus something else.
Right. If someone took benzos along with something that causes seizures, like a tricyclic antidepressant or cocaine, the benzodiazepine might actually be protecting them from seizures. Giving flumazenil would remove that protection and could unmask life-threatening seizures or cardiac arrhythmias.
Wow. So reversing the benzo could make things much worse.
Potentially, yes. The risks often outweigh the benefits of simply waking someone up quicker, especially since pure benzo overdose, while causing deep sedation, rarely causes fatal respiratory depression on its own if the airway is managed.
So is there any role for flumazenil?
Very limited. Maybe in a young child with a purely accidental, witnessed ingestion of only a benzodiazepine where you want to avoid invasive tests. Or sometimes to reverse conscious sedation given for a medical procedure if you're absolutely sure the patient isn't benzodependent and didn't take anything else. But in the undifferentiated overdose patient, most toxicologists say no. Supportive care is the way.
That's a really powerful insight. Reversing isn't always the answer. Okay, next. Octreotide for sulfonylurea-induced hypoglycemia. Sulfonylurias are diabetes meds.
Yes, older class of oral diabetes medications like glyburide, glipizide, glipizide, clomuride. They work by stimulating the pancreas to release more insulin. In overdose, they cause profound, prolonged hypoglycemia, dangerously low blood sugar.
And just giving sugar dextrose isn't enough.
Often not. The problem is giving dextrose raises blood sugar, which signals the pancreas, already overstimulated by the sulfonylurea, to dump out even more insulin. So you get this vicious cycle. Treat the low sugar, cause more insulin release, sugar crashes again.
So how does octreotide help?
Octreotide is a synthetic analog of somatostatin, a natural hormone. It works by directly inhibiting the release of insulin from those pancreatic beta islet cells. It basically shuts off the tap that the sulfonylurea turned on too high.
So it breaks the cycle.
Exactly. It's used as an adjunct to dextrose. You still need to give glucose to treat the immediate low, but octreotide prevents the rebound hypoglycemia. It's considered when hypoglycemia keeps recurring despite dextrose, especially if you suspect a sulfonylurea overdose.
Makes sense. We've covered a lot. Let's hit tricyclic antidepressants, TCAs. Older drugs, but still cause problems.
Definitely. TCAs, like amitriptyline, nortriptyline, they're still used, and they remain a significant cause of overdose deaths. The main dangers are severe cardiotoxicity and CNS effects.
What kind of cardiotoxicity?
Primarily sodium channel blockade, similar to what we discussed earlier. This leads to that QRS prolongation on the ECG, potentially deadly ventricular arrhythmias like torsades de pointe or ventricular fibrillation, and severe hypotension. CNS effects include sedation, coma, and seizures.
And the key treatment for TCA overdose is?
Sodium bicarbonate. Intravenous sodium bicarbonate is the cornerstone.
Why bicarb? Again, same reasons as before.
It helps in a few ways with TCAs. It provides extra sodium to compete with the TCA at the cardiac sodium channels, helping overcome the blockade. It also makes the blood slightly more alkaline, which decreases the binding of the TCA to those channels. And it can help improve blood pressure. We administer it for QRS widening, any wide complex dysrhythmia, hypotension, even sometimes for seizures related to TCAs. The goal is usually a serum pH around 7.50 to 7.55.
What about getting the drug out? Decontamination. Dialysis.
Generally not very effective for TCAs. They're absorbed very rapidly, usually within an hour or two. And they have a huge volume of distribution. They spread out into body tissues quickly, so there's not much left in the gut for charcoal or lavage after an hour, and very little in the blood for dialysis to remove. Plus, their anticholinergic effects slow down the gut, making even activated charcoal less useful. So supportive care and sodium bicarbonate are really the mainstays.
Okay. Last one on our deep dive list. Salicylates. Aspirin. Sounds common, but you said the toxicity is complex.
Very complex. Salicylate poisoning, usually from aspirin, presents with a whole constellation of issues. GI upset, nausea, vomiting, characteristic acid-base disturbances classically, an initial respiratory alkalosis from breathing fast, followed by a significant metabolic acidosis, neurological effects ranging from tinnitus, ringing in the ears, to confusion, seizures, coma, acute lung injury, and hyperthermia, high temperature.
And you mentioned earlier there's no specific antidote for salicylates.
That's right, a crucial point. There is no specific antidote for salicylate poisoning. Management relies heavily on good supportive care, trying to limit any further absorption if possible, and the absolute mainstay, enhancing elimination.
So how do we enhance elimination for salicylates?
Urinary alkalinization is key. Just like we discussed before, giving IV sodium bicarbonate to make the urine alkaline, pH 7.58, traps the salicylate, which is a weak acid, in the urine and dramatically increases its excretion by the kidneys.
Does alkalinizing the blood help too?
Yes, maintaining a slightly alkaline blood pH around 7.45, 7.55 is also important. It helps keep the salicylate ionized in the blood, which prevents it from crossing the blood-brain barrier into the central nervous system, where it's particularly toxic.
So bicarb is critical.
Yeah.
Any big cautions with salicylates?
A major one involves airway management. Sedating someone with salicylate poisoning or intubating them without careful attention to ventilation can be incredibly risky.
Why?
Because patients with salicylate poisoning are usually breathing very rapidly to blow off CO2 and compensate for their metabolic acidosis. If you sedate them and their breathing slows, or if you intubate them and don't maintain or even increase their ventilation rate, their CO2 level will rise. This worsens the acidosis, which then drives more salicylate into the brain, potentially causing rapid neurological deterioration or death.
Wow. That's incredibly specific and critical.
It really is. What's fascinating here, clinically, is how understanding that underlying physiology, how a weak acid like salicylate behaves at different pH levels in different body compartments directly translates into these precise life-saving strategies, or potential pitfalls if you get it wrong.
What an absolutely incredible deep dive. We've really journeyed through this multifaceted approach to overdose management, seeing how, supportive care is often that unheralded hero.
Absolutely, the foundation.
While the antidotes, when they exist and are appropriate, play these incredibly precise, vital roles, but each with its own set of, surprising considerations and challenges.
It really underscores the vital role of all healthcare professionals, but maybe especially pharmacists, in this whole picture. Reducing poisoning injuries and deaths from helping with early recognition, advising on antidote stocking and selection in hospitals and communities, guiding emergency teams on the proper dosing and monitoring. It's a critical contribution, often working behind the scenes.
It really is.
Yeah.
And considering just how complex, how nuanced all this treatment is, what does it make you think about that common phrase we hear? Just give them the antidote.
Right, like it's always simple or always the first step.
Yeah. And how much more goes into truly saving a life beyond that single, sometimes almost mythical solution? It's, I think, a real testament to the continuous learning, the constant updating of knowledge, and the informed decision-making that's required in critical care. where every single piece of that knowledge can have just an incredible life-altering impact.